So let's get started. So I'll basically talk about all of this stuff in the next like 20 minutes. I'll try to keep it pretty quick. Sorry if I rush through it all. I just don't want to keep you guys waiting too long. Um, so yeah, just a quick review of the anatomy of the colon and like how we poop. So basically the rectum gets filled with poop, and then there's like this sensory nerve stimulation that dilates the bowel walls. And there's these afferent fibers that send signals to like the defecation center. And that sends motor impulses to the descending colon and to the sigmoid and rectum via efferent nerves. And as the stool enters the upper canal, then the sphincters relax and just like a quick review of like constipation as a whole. Like constipation is used so casually. It's usually like people say it when they're having hard poops or large poops or like really infrequent ones. But formally by NASPGHAN, which is like the North American Society for Gastrohepatology and Nutrition, they specify that it should be there for like a minimum of 2 weeks, and we'll get into functional constipation as well. Constipation overall, though, creates this like super awful cycle that has like painful poops and or like defecation, and especially in like little kids, it'll cause voluntary like withholding because it doesn't feel good to go, right? So they'll keep that stool in their rectum, which then leads the body to like kind of absorb all the fluid, and it makes the stool even more hard and more painful. And that kind of creates this like kind of awful cycle. And especially when it's before toilet training, it can lead to even more issues. And it leads to desensitization of the nerve cells. And so then it becomes like harder to recognize that you have to go as well. So we're trying to break this cycle here. So overall, the causes of constipation, most of it is functional constipation, like 95%. And functional disorders now are like kind of called disorders of the gut-brain interaction. This falls under that. And then of the other 5%, the most common condition that we want to differentiate from when we're talking about constipation is Hirschsprung disease. 50% of kids with Hirschsprung actually pass meconium within the 48 hours. So like, even though I'll get into like getting a good history, even if they say, oh yeah, baby pooped like right away, 50% of kids that are ultimately diagnosed will still have done that. And so fecal impaction and constipation or failure to thrive and all of these things can be presenting signs of Hirschsprung. Yeah. And so here's the definition for functional constipation. With the Rome 4 criteria, the child must have 2 or more of the following for at least 1 month, and they go based on developmental age of the child. So not just chronic, not just chronology. So yeah, even if the kid is going more than 2 times a week, if they're still having like 1 episode of incontinence a week, or they have really painful bowel movements, just that alone can still qualify as functional constipation. You want to make sure that the kids don't meet criteria for IBS, but I just want to like show you the Rome 4 criteria to show you that it's not just the number of times that they go weekly. It's also like the quality of that stooling frequency. I mean, the stooling itself. So a history is really important when you have a kid coming with constipation. I know that can be really difficult in the ED, especially when you're like, oh, this is the least of my problems, but just getting like a quick story so that you understand what exactly is going on. You want to make sure that you're asking the age of onset. Like I mentioned with the Hirschsprung, like if you have a kid that the constipation started at less than 1 month old, mom is like, oh, it's been going on since birth. That should be sort of like a signal to you that this is probably not just functional constipation. There could be a more organic cause underlying it. You also want to get a little more on like social history that can play a role, developmental history, and see if there's like any systemic symptoms, any failure to thrive. And just so that you guys are aware, like normal stooling patterns, like in infants, for example, they'll have like 3 to 4, maybe even up to 7 poops a day. That's normal for them. For children around like 2 years old, we'll say like 1 to 2 a day. And then by adulthood, you're having adults that go like 3 times a week or even 3 times a day. That's normal. And this pattern is usually attained by the age of 4 years. So on your physical exam, you just want to make sure that there's no, like, for example, neural tube defects, that the kid doesn't have failure to thrive. Sometimes if they have a really large stool burden, which you'll often see in the ED when they're coming in with like really bad fecal impaction, is a palpable mass in the left iliac fossa. I remember there was once a girl, like a 15-year-old girl, who came to the Kings County ED, and honestly, like, we questioned whether or not she was pregnant because she had that large of a fecal mass. It was actually megacolon at that point. But yeah, so making sure to do a good exam is really important. You'll also sometimes, I mean, technically always, but like especially in babies, you'll want to make sure that the anus is like correctly placed, because that can affect the stooling too. For red flag signs, constipation, like I mentioned, starting really early in life at less than 1 month old, or passing meconium late, family history of Hirschsprung disease, anything else, including like bilious vomiting or the thyroid being abnormal, tuft of hair in the spine, sacral dimple, all of these things are red flag symptoms that you're not just going to write it off to like, oh, a functional disorder, here's some Miralax by. These are things that you do want to refer to GI or consult them while they're in the ED. And so now we get into NASPGHAN's kind of like algorithm to the approach for constipation. You'll see here that there's, let's see, first they like talk about doing like education, demystification for like functional constipation. If you've ruled out the alarm signs and now you're saying this is likely functional based on the history, you do want to talk about like the physiology briefly, just so families understand and are not ashamed of it. You want to like understand where they are at toilet training. And then you want to assess, are they impacted or not? If they are, which one of the things that we do in the ED frequently is disimpaction, and I'll briefly get into that. And then after that's successful, ideally, we'll initiate maintenance therapy. And I'll quickly go over that as well. And I just want to highlight that maintenance therapy is supposed to last for at least 2 months. So sending a kid that has functional constipation home just with like 1 week of Miralax, maybe their symptoms will be resolved by like for that 1 week or maybe for a week after, but it's just going to come right back. And especially if they're not seeing their PCP regularly and they're not really following up, they're just going to end up right back in the ED with constipation again. So we need to make sure that they're taking Miralax for at least 2 months. Pharmacologic treatment overall for constipation is going to be disimpaction, the maintenance treatment, and then finally the weaning. We use osmotic laxative, primarily polyethylene glycol, which is Miralax, as the drug of choice for disimpaction and for maintenance treatment. Enemas overall is not preferable. We prefer to go like the NG route, and I'll get into that as well. Also, polyethylene glycol is more effective for maintenance therapy compared to like lactulose or milk of magnesia, or even placebos. We don't recommend just saying, oh, change your diet, and that'll solve everything. It's not going to be like a treatment for functional constipation. It might be preventative for future constipation though. And Senna is a stimulant laxative, and it's not really recommended for long-term use because it can cause electrolyte abnormalities. So I put here like the CHOP guidelines. It's really small for disimpaction, or just like their approach to functional constipation as inpatient. Everything that I've been talking about so far is for kids that are like more than 6 months old. If a kid that's less than 12 months comes in, we can give them like a glycerin suppository for disimpaction. And then if they're 12 or more months, we can do disimpaction with with a glycerin suppository, but ideally it would be like Miralax Clean Out. Something that we do in GI clinic is they don't even have to be in the hospital for this. If it's not so bad, they just take a boatload of Miralax. You tell them to take like 5 capfuls, for example, on a weekend when they know that they're going to be home, and just, totally empty out their bowels. And then once they've done that, then we can have them go on like a regular maintenance dose, which is like 1/2 cap or 1 cap a day. And then you can tell them to like titrate it just so that they're getting like a soft, I say like a soft froyo poop once a day. We don't want them having diarrhea. That's going to lead to like poor compliance with the treatment for a whole 2 months. But we do want to kind of set that expectation, especially in the ED, that this is something that they'll be on like long term for at least a couple months, and then hopefully like wean it down just while the body sort of recovers. Let's see. So yeah, like I mentioned, like fiber supplements and extra fluid intake, those are not things that will treat the constipation. They do need the Miralax. And I think like the biggest thing is when parents come to you guys in the ED, I think like just like sort of like setting up that education background, like telling them that this is something that they should follow up with their pediatrician with, or if someone's come in like more than one time for constipation, they're coming into the ED like 2 times, 3 times, just send them to GI for like I would say like just give them a referral for constipation management, just to make sure there's nothing else underlying going on, and so that we can like make sure to treat them appropriately. After they start on the Miralax, like at around 2 weeks after starting, we would assess the need to like increase or decrease the dosing, and then follow up with them at the 2-month point. But basically, I know that time is really limited in the ED, but just so that you guys have an understanding at the very least, like the colon, right, is a muscle. So when you're stretching that out, you have the desensitization of the nerves. Like just because the poop is softer and coming out easier, you still need the muscle to kind of go back to its normal shape, right? And just like any other injury, it takes time. So that 2 months gives the body time for the diameter, circumference of the rectum and the colon to decrease, and then for the body to go back to its physiologic state. Yeah. So this is the guidelines from NASP again that we used for this presentation. And there are like other articles that you can read just to show that like Miralax is the medication or treatment of choice for constipation, and that it is superior to the placebos like milk of magnesia, lactulose. An alternative to Miralax, if the kid can't take Miralax or can't access it for some reason, is lactulose. That's the preferred one. But Miralax is safe. If any parent asks you, like, is it okay to be on this for so long? It is safe to do so. So just a quick overview, constipation is such a common problem. Like 50% of the kids that have it will relapse. So it's really about making sure that they have established care, which you guys are often, I feel like the go-to place. I think emphasizing like follow up with the pediatrician for this. It's not something that always warrants an ED visit is a big thing. And then our QI project, like the SMART aim is just to make sure that we're prescribing it appropriately and giving referrals appropriately. Yeah. So functional constipation is a 2-month minimum treatment time. First line is Miralax for treatment, and just like educating the importance of medication compliance, I think will prevent them from coming back so frequently to the ED. And then also I forgot to mention, like oftentimes it's kids that have like autism or other developmental disorders, anything that has to do with like sensitivities, like with going to the bathroom, that can also mean that they have like coinciding pathologies, not just the functional constipation, but oftentimes they have like nutrition, like malnutrition because like very limited diet. These are things that GI can also take care of if you guys want to give referrals from the ED as well.